Hello. Good afternoon, friends. Welcome to this ENT session where we are going to discuss the recall questions of MCI exam that was held recently. I'm your ENT faculty, Dr. Sanjay Aggarwal, and I've been teaching ENT for nearly 20 years now, 2 decades. Next year, I'll have completed 2 decades of teaching ENT. And I've written books for MCI students, for PG students, so you can check the names on the screen. Now, before we start the questions, you know about this iconic subscription, don't you? It's a combo pack of a subscription and an app. I think students are really loving this. I'm sure you'll check this, and if you like it, you can get the details of this because there are various packages, so you can look for it on the website. Now this is, you can lock the free plan on the Unacademy app. You have to download the app and you can use this code drsanjay10, and then maybe you can download this app and then get all the benefits of this. So with this very short introduction, we'll start straight away with the questions that were asked. So as we proceed, I would really love if you can keep answering the questions on the comment on the chat below, so that I know whether you understand or not. And if you have any questions, query regarding that question or anything in ENT for that matter, you can just put down on the chat. I'll try to answer as many questions as possible. Okay. Now, for those who have written the exam would know that this was a relatively easy exam, and ENT questions were not very tough. Almost all the questions I can say are from the lectures that we take in the classes. Almost all the ENT questions were either directly or indirectly from the classes. So I'm sure you will get very good mark if you have sincerely attended all the lectures and done the revisions also. So first question, which of the following is cause of nasopharyngeal carcinoma? Epstein-Barr virus, herpes simplex virus, parainfluenza virus, herpes zoster virus. Now in the lectures that we had for MCI, I told you then so many times that last year, not last year same time, December exam, there were 2 questions from nasopharyngeal carcinoma, and I told you it's a very important topic and they're likely to ask questions from nasopharyngeal carcinoma again. And surprise of all surprises, this time around they again asked 2 questions, again 2 questions from nasopharyngeal carcinoma. Last time 2 questions, this time again 2 questions from nasopharyngeal carcinoma. So that tells us that nasopharyngeal carcinoma is a really important topic, and I warned you that you must read this topic very nicely because they'll ask you questions from here definitely. And there are 2 questions. Last year they asked you, they asked I think the most common presentation, that was lymphadenopathy, and the second was treatment of choice, chemoradiation. This time one of the questions is the cause is which virus actually, and we all know it's Epstein-Barr virus. Everybody has been able to answer this correctly. So besides Epstein-Barr virus in nasopharyngeal carcinoma, we have genetics as a cause, people who are genetically predisposed, and a chemical called nitrosamine, which Chinese eat, and that's why this tumor is very common in Chinese people. Yes, lymphadenopathy also given, right? You're right, Levity. So all in all, it's an important tumor from MCI point of view topic, this nasopharyngeal carcinoma. No, the second question was about, I think, Trotter's triad. It was related to Trotter's triad. And the other important things you have to know about this tumor is the site. We all know fossa of Rosenmuller. Then most common type. Can you answer this question? Which is the most common type of carcinoma in the nasopharynx? If you like to answer this question, let's see who gets this. Most common type of nasopharyngeal carcinoma is undifferentiated. Undifferentiated squamous cell carcinoma, and some, they are divided into type 1, type 2, type 3. So this is type 3. There are two classifications. One classification says type 1, type 2, type 3. There is another classification which says type 1, type 2A, type 2B. So type 2A is same as 2, this is same, and these two are same. So if they ask you which are the following type, then look for any other two. Either type 3 is given or 2B is given. Both are correct answers, the most common type. And then we already know that most common presentation is lymphadenopathy. Now regarding lymphadenopathy, which lymph node is most commonly present? Which lymph node most commonly presents, and which lymph node is the first to involve? These are two different questions and there are two different answers. In nasopharyngeal carcinoma, which is the first lymph node that gets involved is retropharyngeal lymph node. This is the first lymph node to involve, but this is not the first lymph node to present. The first lymph node to present is group 2 lymph node, which is upper deep cervical. It's called upper deep cervical lymph nodes. Treatment, I told you, chemoradiation is the treatment. It's the most radiosensitive tumor. Most radiosensitive tumor in the head and neck. And then there is Trotter's triad, but we have a question on that regarding that, so we'll talk about that when we come to that question. So these are some of the important points related to this tumor that one must remember. Very, very important. Next question. A patient met with roadside accident. Following this, he had nasal discharge which looked like the image. Which sign is this? Halo sign, sword sign, handkerchief sign, Phelps sign. So I'm getting a lot of people saying halo sign, A, which is indeed a correct answer. Halo sign is sometimes also called target sign. Yes, correct, AB. Target as in dart. When we draw dart, we make in the center there is different color, then there are different colors all around. In this it is same color, but you have rings, so you have to hit the center, the target, shooting, archery or even dart. So that's target. So it's called target sign. It looks very similar. Now tell me, is this sign seen in all patients of CSF rhinorrhea or any specific type of CSF rhinorrhea? Can you answer this question? Target sign or target halo sign, is it seen in most of the patients of CSF rhinorrhea or some specific cause of CSF rhinorrhea? Which one? Can you answer this question? Let's see. What do you say? Or what do you have to say? Halo sign and target sign is only seen. I had asked this question in one of the MCQ based lectures that I had taken on special classes. One of the free classes, I had asked this question, same question, that target sign is seen in only traumatic CSF rhinorrhea. As somebody is rightly saying, because trauma causes bleed also. And rest of the causes of CSF rhinorrhea, like they're congenital, dehiscent, or tumors, or raised intracranial pressure, empty cella syndrome. So there are many other causes of CSF rhinorrhea in all those patients because there is no bleeding. So there is no halo sign. This is only for patients who have bleeding. So this red thing that you see in the center is blood. And this is a blotting paper. I'm sure you know. This is a blotting paper. So when the patient has CSF rhinorrhea and there's watery discharge coming from the nose, you allow a drop to fall on a blotting paper. So where the drop falls, that area becomes most red, dark in color, and as it is spreading all around, the darkness keeps on decreasing, so it becomes more and more light, and ultimately there is only water. Can you see the light? The last layer is only water, you can see. So because the blood can travel only up to a certain distance, because there is only a limited amount of blood cells, and that's why it gives you this kind of a feeling. Now, another question we ask is, what is the treatment of choice in CSF? What do you say? Can you write the treatment of choice in a patient of CSF rhinorrhea? Please answer this question. I'll tell you about handkerchief sign. I'm just waiting. I'll tell you about handkerchief sign. But before that, answer this question. What is the treatment of choice? Now, you must have read books or attended classes. We always say conservative management. Conservative for 1 to 2 weeks. Now, once again, conservative is done only for traumatic purpose, traumatic patients. Because trauma causes fracture of the bones, cribriform plate in this case, and bones fractures, they heal very well. We know this, isn't it? Bone fracture, they heal very well. So waiting for it to heal, fracture will heal, and once the fracture heals, the gap is gone and the CSF flow is gone. So this is only applicable to traumatic. And I can say that almost 95% of the CSF rhinorrhea are due to trauma. The rest of the causes put together is only 5 to 10%. And in those cases, you have to treat according to the disease. If there is a tumor, suppose there is a tumor causing erosion of the skull base, then you have to do the treatment of the tumor, surgery or radiotherapy or whatever it is required. If there is raised intracranial pressure, then you have to find the cause of the raised intracranial pressure and decrease the intracranial pressure, and that will decrease the CSF flow, right? And if there is a congenital dehiscent gap in the skull base, then you have to do a surgery and close the gap. So when we say conservative management, we are assuming it is traumatic. We are assuming, and they are the most of the patients, and these are the ones who will have this target sign. One of the major problem in CSF rhinorrhea is when the blood, if there is no history of trauma, or if there is a history of trauma also, sometimes it happens. When we get confused is, suppose somebody had a trauma today, roadside accident today, the CSF flow does not start straight away. It happens after few days, 3-4 days later, the patient starts having CSF flow. And you are confused, is it CSF or nasal discharge? And so CSF versus nasal discharge, CSF versus nasal discharge, there are few points, and we all know, we have done this in the class. In CSF, we have a halo sign. In nasal discharge, we have handkerchief sign. So handkerchief sign has nothing to do with CSF rhinorrhea. It is just to differentiate a CSF from normal nasal discharge. Because normal nasal discharge has mucus. CS has no mucus. Obviously, mucus comes from the nasal glands. CSF does not have mucus. So what you do is, in handkerchief sign, it's a very dirty kind of thing. You have to blow your nose in the handkerchief. So when you blow the nose, if it is nasal discharge, then what happens? The mucus also comes in the hanky, and let it dry for some times. So once it dries, If there is mucus in that discharge, then that area of the hanky becomes very stiff. There is stiffness. This is called handkerchief sign. But in CSF, because there is no mucus, there is no stiffness in the hanky. So that's called handkerchief sign. Right? And there's so many other points. I'm not going to go into the details, but the important ones I'll tell you anyways is that CSF has beta 2 transferrin, and the glucose content in CSF is more than 30 gram. So because glucose is too much, it is sweet. It is sweet in taste. Of course, nobody tastes it, but it has to be sweet because of glucose. In nasal discharge, the glucose is less. So it is not sweet. It's more of salty, right? So this is what the handkerchief sign is about. And Schwartz sign is seen in autosclerosis. We all know this is nothing to do with this. And Phelps sign is glomus tumor. Isn't it? All this we know. So I hope it clears all your questions regarding this particular topic. Then we have third question, straightforward. I think 100 out of 100 will get this right. Must have got it right in the exam also. The image was obviously different, but you have to make a diagnosis: rhinosporidiosis, rhinoscleroma, rhinophyma, none of the above. Of course, we don't get all the choices, so we sometimes, to fill in the gap, if we don't get all the 4 choices, we put our own choice accordingly, according to our understanding. And as suspected, everybody has to get it right. Rhinophyma, which is also called, as somebody is saying, potato nose. There is one more name. Anybody else? Any other name you can call it by? Any other name? Pooja, Satya, AB, Chandran, Chandan. Any other name of rhinophyma? It's also called elephantiasis of nose. It comes from the disease elephantiasis. But although it is called elephantiasis of nose, it has nothing to do with the disease elephantiasis. It's not related. It's a very different kind of disease. Elephantiasis, I'm sure we know, is filaria infection, filariasis, isn't it? In West Bengal and Bihar. But this one is just because the nose look big, it's hypertrophy of sebaceous gland. In elephantiasis, there is a blockade of the lymphatic drainage, and because of that, there is lymphatic collection and all that. But this one has nothing to do with it. It's a very different kind of disease. Just the name is similar because it looks very similar. The nose looks like, in elephantiasis, it is mainly the limbs, lower limb, essentially lower limb, genitalia. All that area has swelling, enlargement of the limbs and the genitalia, and looks like an elephant. So elephantiasis. This also looks big, enlarged like an elephant. So elephantiasis, but nothing to do with that. And it's a cosmetic problem, so cosmetic surgery has to be done. And it is seen very much in patients with acne rosacea. People who tend to have acne rosacea, these are the patients who also have this rhinophyma, potato nose. And rest of the 2 conditions are also very simple. Most of us know anyways that rhinosporidiosis is strawberry polyp, and it's called by Rhinosporidium seabury. Rhinosporidium seabury, which is seen in the coastal areas of southern India mainly, and present as strawberry polyp, as we call it. Whereas rhinoscleroma is called by Klebsiella, rhinoscleromatis, and there are 2 types of cells. One is called Mikulicz cell and Russell body. In both these conditions, they ask you the drug of choice. Which is the drug of choice for rhinosporidiosis? Which is the drug of choice for rhinoscleroma? So the drug of choice for rhinosporidiosis is dapsone, and in rhinoscleroma it is streptomycin. Streptomycin is the drug of choice in rhinoscleroma. Dapsone is the drug of choice in rhinosporidiosis. And I always say that you should always study these three conditions together, because of similar sounding names you get confused, and in the choices they are often together. I keep telling you in all my lectures that in the choices, if no matter what they ask you, whichever of the three, but they will always have these three in the choices. And the fourth choice sometimes they give is rhinolith. And because these terms have rhino in it, the examiner thinks that you might get confused, and therefore they try to ask. And rhinolith, you know, is old calcified foreign body in nose, isn't it? And it presents as unilateral bleed and foul smell from the nose, plus minus discharge also from the nose, right? So this will complete all the important points related to rhinophyma and the related topics. Next question. All of the following can cause croup except. Now this is another, you can say, that interesting question. It's not tough, it is interesting. Now, is it parainfluenza virus 1, parainfluenza virus 2, rhinovirus, Haemophilus influenza? So which of the following does not cause croup? So what is your answer, friends? Let's see, what do you say? Croup, we all know, is also called laryngotracheobronchitis, isn't it? And it's a viral disease, most commonly caused by virus, although it is most commonly caused by parainfluenza virus type 1 and type 2, both of them, but can be caused by rhinovirus also. Haemophilus influenza is a bacteria, and croup is not a bacterial disease. Haemophilus influenza mainly causes epiglottitis. Now in the throat, now why is this important? Why is this important? In the throat, virus versus bacteria, how do they present? See, virus will attack suddenly. We are talking about throat, respiratory tract infection. Then it spreads very fast. And relieves quickly. So it comes, attacks, spreads and goes away. Within few days everything will happen. And the patient is normal within 3-4 days. That's what happens. So here the main point is it spreads very fast. Because it spreads very fast, it involves the larynx and trachea and the bronchus. See, you have to involve the larynx and the trachea and the bronchus, a lot of areas. So you need a disease which can spread very, very fast. And this is a very typical feature of a virus. Whereas bacteria, they tend to localize or colonize. Localization and colonization happens in bacteria. So they will form abscesses, they will stay in one area, they don't spread easily. Of course, they can also spread, but not as often as virus. That's why this becomes important. So when the patient has a throat infection, sore throat, this is very important in clinical. Now when the patient has a sore throat infection, and we don't know it is viral or bacterial, because the treatment will depend on virus and bacteria different, and you want to know is it viral or bacterial, one of the first question we ask is, does the patient has cough? Because if you have a sore throat, if I draw it like this, throat infection is here, isn't it? And coughing can happen only when the larynx or the trachea gets involved. Only when the larynx or trachea gets involved, only then the patient starts having coughing. So, if the patient has a cough, that means the infection has spread from throat, attacked the throat, it has spread to the larynx and the trachea. That's why the patient is having cough. So the chance of having viral is very high now. But if the patient does not have coughing, that means the trachea larynx is not involved yet. So the infection is localized to the pharynx. So the chance of bacteria is very high. So that's why these simple things. And why is this important? Because in a clinical history, when they give you a case, a child comes to you with sore throat, difficulty in swallowing, pain in the throat, and has dry cough, So dry cough with sore throat means virus, and no cough. They say no other feature, no cough, no fever, no this, that. So if there is no coughing, that means bacteria is the likely cause. So that's why this simple one word, two words can make a huge difference, especially in a clinical case type of case. This time they did not ask you clinical case, but if you remember the last exam, the one which was held in the midterm exam, in that there was all the clinical exams were there. All of them were clinical exam. And after that, I told you when I took a lecture that this time they're not going to ask you clinical exams questions, because the result was very bad and a lot of people were depressed and things like that. So obviously examiner is at the end of the day a human being. He doesn't want you to suffer. So he gave you easy questions so that most of you do well, clear out. So it's a happy world. As it is, we are going through a very bad times, corona and all that. So we want everybody to be happy. Schools are closed, colleges are closed, people are at home. So exams should be also simple. That's why the whole idea. So how to differentiate between a throat infection of bacteria and throat infection of virus becomes important from the clinical point of view, and you should know this. This is not only exam, also clinically practice. When you start practicing, these simple things matter a lot. These are the things that will decide whether you are a good clinician or a not so good clinician. Everybody will complete the course eventually. Everybody will become a doctor, practicing doctor eventually, but then some become very good clinician, some are average clinician. So these simple things matter. These are the ones that make you stand out of the crowd. Next one, investigation of choice for juvenile nasopharyngeal angiofibroma. Now this question can be considered as slightly tricky questions, but what is your answer? First, contrast enhanced CT scan, MRI, X-ray, angiography. So I want you to answer this question. Please answer this. CT scan, MRI, X-ray, angiography. Now the answer will really depend on the language of the question. Here the question is investigation of choice. And then CT scan, contrast enhanced CT scan becomes because it is also considered as the gold standard sometimes. Because it will show you tumor or growth. It will show you by and large vascularity also, because it's a vascular tumor, and it can show you by and large feeding vessel also, and bony erosion, which is very important, and spread. See, it will give you so many information, and it's relatively cheap. It's not very costly. Like MRI, angiography are very costly. They are also good, but they are costly. So if you're going to get the same information, same value, then spend less money, isn't it? That's the whole logic. That's why MRI will not show you the bony erosion, and this tumor spreads to bony erosion through bony gaps. That's why it becomes very, very important. Now, angiography, or to be more precise, digital subtraction angiography, is usually required because it helps in surgery. Now, do you know what is the treatment of choice? The treatment of choice is embolization followed by surgery, surgical excision. And surgery is either laser or bipolar, right? Now, embolization means block the blood vessel. So you have to block the blood vessel which is feeding. Although the most common vessel that feeds is sphenoplateral artery or maxillary artery, so most of the time we do embolization in maxillary artery, but sometimes we have branch from internal carotid artery also. Sometimes you can't block the internal carotid artery. If you block the internal carotid artery, then the patient will have hemiplegia. A branch from the internal carotid comes to supply, so you may have to block that branch. So you have to know where the blood is coming from, so that you have to embolize. So during the management, it becomes quite important. And I told you it's a costly surgery. It's also slightly risky. Not only this, it can also tell you a lot of information. Out of this, many information can be given by this one. So think about this, that when you suspect a patient of angiofibroma, to diagnose, investigation of choice. Investigation of choice means for diagnosis. Confirm. For diagnosis, you'll do CT scan, and after you're diagnosed, you'll decide the treatment, and then you'll try to do embolization and surgery. And for this, before this treatment, you'll get another investigation done, angiography or digital subtraction. You're doing two investigations. The patient has to spend more money. The patient has to take more trouble. Twice he has to go to the investigation center. Both are risky because in both you have to inject dye. In contrast enhanced CT scan, you have to inject some dye. In digital subtraction also you have to inject some dye. So twice you are injecting dye in the patient, so more risk in the patient. So why go with all the trouble? Why not just do one investigation? Saves money, saves time, saves the risk, everything, and radiation exposure to the radiation, everything is saved. So what I do is I always go for digital subtraction angiography, because ultimately this has to be done. But to get this done, you have to have a very strong suspicion of this disease. When the patient comes to me, I must be experienced enough, I must have enough knowledge to know that this is perhaps a angiofibroma. My simple investigation, anti-rhinoscopy, endoscopy tells me it is, this tumor. And then instead of going for CT scan and then angiography, just go for angiography and takes care of everything. It saves a lot of hassle to the patients. So that's why many a times angiography becomes a better answer. Which are the following investigations will you do? A patient with, angiofibroma is seen in small child, a boy, kids. So suppose they ask you, a 12-year-old boy with epistaxis and cheek swelling. On examination, red mass with bleeding in the nasal cavity and nasopharynx. Now, with this history, and you have planned to do surgery, which is the investigation you'll do. See, now you'll do angiography because you have already high suspicion. It is not confirmed yet because you have only history and examination, but there's no confirmation. But still, there's a strong suspicion that the child is having juvenile angiofibroma. So why go for CT scan and then angiography? I know I have to do surgery. I'm already decided, most probably. And angiography is not only for surgery, it's also going to help me diagnose. It will give me a lot of information that CT scan gives me. So that's why angiography becomes better now. So you have to be very careful about the language of the question sometimes, because little bit of change in here and there can change the answers also. Okay. Next question. Which of the following is a treatment for atrophic rhinitis? Again, another very important topic. In last year, they had asked question on atrophic rhinitis in the NEET exam. This year, they are asking you the question in MCI exam. So tells us that this is another important topic. So these are the topics that we teach in the exam. Everybody, not only me, all the faculties, they will teach you the same topics. So at least you know which are the important topics. Question might change. Topics never change. That's why we said topics never change. The question change, the frame change, the choices change. The topics remain the same. So if you know the topics, then it helps you a lot. So what is the answer in this case? Steroid spray, Young's operation, immunotherapy, NSAIDs. I think again Most of you must have got it correct. So what do you say? The correct answer is B, Young's operation. Young's operation. Right. Correct. Now we all know atrophic rhinitis. You have to know few things like cause. What is the cause of atrophic rhinitis? There are many causes. Most common cause is decreased estrogen. A bacteria called Klebsiella oziana. That's why the name is also oziana. One of the names is oziana. And treatment, there is merciful anosmia, isn't it? One of the features is merciful anosmia, we all know. Now treatment, most important thing is, if the estrogen is less, you have to supplement estrogen. If there is this bacteria, then you give streptomycin. But there is alkaline nasal douche, very important. There are 3 salts: sodium bicarbonate, sodium biborate, sodium chloride, isn't it? Then surgeries like Young's operation, modified Young's operation, and Lawton-Slager surgery. In PG exam, they also ask you what is done in Young's operation, what is done in modified Young's operation, what is done in Lawton-Slager surgery. You have to know that, but not now. For PG exam, you have to know all this. Right. Now, very interestingly, atrophic rhinitis versus rhinitis sicca. Now, these two conditions, they present very similarly. Both have dryness in the nose, both have crest formation, both have foul smell from the nose, both can have bleeding. All this is possible. So how do you differentiate? One is cause, second is site involved. These are the two main things, and therefore the treatment varies. Atrophic rhinitis is described as, I always describe this as local presentation of systemic problem. It's a local presentation of some systemic problem. So there's some systemic problem, disease, and in the nose there is a presentation. So what is the systemic problem? See, if it is decreased estrogen, it's a systemic problem, right? Then vitamin D, the other causes, vitamin D deficiency is a systemic problem, can lead to atrophic rhinitis. Then some races, some racial groups have atrophic rhinitis very common, so it's a racial problem, So that's why I say autoimmune condition or a systemic problem. So this is a local presentation of some systemic problem, whereas rhinitis sicca is due to hot and dry air that the patient has to breathe. So there is no systemic problem. Patient is breathing hot and dry air. That dry air is causing this dryness in the nose. People who are working in front of the fire, basically, if you have to stand in front of the fire for long duration of time, people in the furnace, steel factories, furnace factories, copper factories, goldsmith who are working with the lot of fire, they are playing with the fire. So these people began to have this one. That's why this is entire nose is involved, the whole nose. This one, only the exposed area. Which is the exposed area? The nostril area. So the nostril area, which is antero-inferior part, antero-inferior part, not the whole nose. But in atrophic rhinitis, the entire nasal cavity is involved, and that's why in this, what do? You treat the cause. You find the cause. As I told you, if it is estrogen, you have to give estrogen. If it is vitamin D deficiency, you have to give vitamin D. If it is infection, you have to give antibiotics. But in this, what do? Just avoid that air. If you can somehow avoid that hot and dry air that patient breathes, then the problem will go away. It's a more local problem, easy to treat. Atrophic rhinitis is a more systemic problem, very difficult to treat. That's why we may have to go for surgical option. In this, there is no surgery, nothing, no surgery is done ever, right? So atrophic rhinitis, very interesting, very important, another important topic. Stop. Then, which of the following is true about BERA? Used for sensory neural hearing loss, is an invasive procedure, is a subjective investigation, used for screening. So please answer this question. Again, simple question. In every lecture we discuss about this BERA in details. Actually, I show you images, I show you graphs also. So once again, which of the following is true about BERA? Used for sensory neural hearing loss, is an invasive procedure, is a subjective investigation, used for screening. So hearing loss, it is A. Hearing loss are of two types: conductive hearing loss, sensory neural hearing loss. This one, sensory neural. So when sensory neural loss is there, it can be of two types. It is either cochlear or retrocochlear. So when the patient has sensory neural hearing loss, then it is either this one or this one. I need to find out, because the treatment will depend on that. And BERA can be done. One of the best investigation for this, one of the best, is BERA, to differentiate cochlear from retrocochlear. So that's the first thing we see in BERA, that this is to differentiate a cochlear disease from retrocochlear disease. Very, very important. Right. Now BERA is also used for screening, but it's not the investigation of choice. For screening of hearing loss, investigation of choice is OAE, autoacoustic emission. So when the patient, for screening, what do? If you have to screen for hearing loss, we first do autoacoustic emission. Now the results are two of this. Either the patient is pass means normal, pass means patient's hearing is normal, or what? Or refer. We don't say fail or disease. Refer is doubtful. We are doubtful in this patient, so we call it refer. We don't say the patient has hearing loss, so we have to confirm, reconfirm. And for this, refer to what? Refer for BERA. Now we do BERA, and BERA will confirm whether hearing. BERA will confirm and also will tell you site of lesion. It can also tell you the site of lesion. So it was screening. We had done this for screening also, but it's not the first thing. Only if OAE refers, then we do BERA. Otherwise, in most of the people, children who are born are normal. We all know, isn't it? Screening is done for what? Screening is done for suspected normal population. In Northern Europe, every child born has to be screened for hearing loss. Every child has to undergo this. In India, it's not a rule. India, you can't afford to screen hearing loss because so many children are born every day. In 1 hour, the number of children that are born in India, in whole Scandinavia, that many children are not born in the entire year, isn't it? The whole Scandinavia, maybe 100, 200 children, maybe 1,000 children or kids are born. In India, 1,000 kids are born every day, more than that. So you can't afford. So in those countries, they are rich country, affluent countries, the birth rate is very, very low. There you can afford to screen. So they do OAE. In India, we do OAE for suspected case, a child low birth weight, child has, jaundice soon after birth, child was admitted to ICU for whatever reason, the child during birth had hypoxia, cried late, these are suspected cases. So like low birth weight, then premature jaundice, hypoxia, ICU admission for whatever reason. So these are some of the indications and meningitis you can see if the child has infection. So these are some of the indications where you do screening. In the children you have to screening. So there's some indications. But as I said, in Europe, every child has to be screened for hearing loss. That's the indication. So you have to do something which is very simple, easy, and which is OAE. Now you might ask me that, sir, if BERA is going to confirm, OAE is not going to confirm, then just do BERA for screening. Don't do OAE. You don't have to do two things. Now BERA compared to OAE is better because it confirms and it gives you a site of lesion also. So it's a better investigation. It gives you everything that you want, but it is difficult to do. It is time consuming, difficult to interpret. So it is more difficult to do, more difficult to interpret, it is more time consuming, and we don't want to trouble a newborn child with all these things. So we do a simple. OAE is simple, easy. It takes only a few seconds to do OAE. BERA takes few minutes, lot of minutes. So that's why. And it is not invasive procedure. Invasive means you have to, put something inside the body of the patient, which is not done. And it is not subjective, it is objective. Subjective investigation is the one where patient's cooperation is required. I'll talk about this. But look at this investigation being done. This is BERA being done. You just put few electrodes on the child's head, and then it is attached to a computer. You switch on, and you get a graph which looks like this. Peaks, and they are peaks: peak 1, peak 2, peak 3. We know this. We have in the lectures we discuss about all this. So there is no invasion here. Nothing goes through the skin, through the tympanic membrane, nothing. Right. So it's a non-invasive procedure. But look at the complications, so many wires, so many electrodes. So it takes a lot of time to fit this. If the child moves here and there, then it will come out. One electrode will come out, then something else. There are many electrodes. You can only see 3, but there are 4, 5, 6 electrodes fitted. Back also, top also, So very cumbersome investment. That's why it's not easy to do. But it is objective. So this, you don't have to ask the child, can you hear or not? Isn't it? Even the child cannot even answer that question. So how do you know subjective or objective? In subjective, you have to ask the patient, and the patient has to respond. Like in audiometry. Audiometry is subjective. We ask the patient, can you hear or not? Tuning fork is subjective. Again, you have to ask the patient. Behavioral audiometry. In this, again, it's a smaller child, but not newborn child. Child of 3-4 years. The child has to look. When the child hears the sound, the child will turn the head, So that's behavior. All these are subjective. BERA, autoacoustic emission, tympanometry, electrocochleography. These are all objective investigations. And in every lecture I tell you that audiometry is subjective, rest all objective, usually. Investigation. Tuning fork is a test, not an investigation. So I always tell in my lecture that audiometry is subjective, all other are objective. So all other are objective for hearing. Not a difficult question. It was a simple question relatively. So I thought you should be able to answer this. Now patient has a pulsation in the tonsil. The likely cause of pulsation in the tonsil is aneurysm of common carotid artery, aneurysm of internal carotid or aberrant internal carotid artery, aneurysm of external carotid artery, or carotid body tumor. So which one of the following can show pulsation in the carotid? I want you to answer this question. Please do answer. Try to answer at least. And the correct answer is B. Either aneurysm of the internal carotid or aberrant internal carotid artery. Now, pulsation in the tonsil can come from a structure which is very close to the tonsil. If you have an artery or an aneurysm far away from the tonsil, then it will never transmit the pulsation. So when we know common carotid divides into two, internal and external. This is external carotid artery, this is internal carotid artery, and this is common carotid artery. This carotid body tumor is here. This is carotid body tumor at the bifurcation, right? And tonsil, let's say, is here. This is your tonsil. Let me use different color. I'll use black. So this is your tonsil with crypts here, in the pharynx. From the tonsil, internal carotid is roughly 1 centimeter deep. If you go 1 centimeter deep from the tonsil, then you encounter the internal carotid artery. So if the internal carotid aberrant means it is not in a normal position. If it shifts a little bit here towards the tonsil, if you start touching the tonsil, then when the blood is flowing through this carotid and the pulsation happens, then tonsil will also move with that. Or if there is an aneurysm, we all know aneurysm is where the wall of the tonsil is enlarged or ballooned out like this. This ballooned out the wall of the, so it is touching the tonsil again, aneurysm of the internal carotid. Again, it can cause pulsation in the tonsil. But if you have aneurysm in the external carotid, you can't. Aberrant, little bit of here and there, if the external carotid goes, it is still very far off of the tonsil. It's not anywhere. It's external carotid is outside actually. We all know external carotid is outside. It's not inside. Tonsil is inside. So external carotid can, and common is very much lower down. In the neck it divides. So carotid body tumor is here in the neck. So this much is neck almost. Till here is the neck. That's why all this cannot transmit pulsation in the tonsil. There are two implications of this point, that internal carotid is 1.1 centimeter deep to the tonsil. There are two implications that I'll tell you. But before that, look at this. This is the common carotid. This dark one is the external carotid artery, and this is internal carotid artery. So external carotid comes on the outside face, supplies all this area. Internal carotid has to go to the cranial cavity. So it travels to the pharynx in the piriform fossa and then goes to the cranial cavity to supply intracranial structures. Internal carotid, we know this. See, this is the internal carotid aneurysm. This is the aneurysm of the internal carotid artery. This is how it swells up. This is angiography showing the aneurysm of the carotid. This is how it looks. Now this is the parapharyngeal space, and this is your internal carotid artery, and the tonsil is somewhere here. This is the area of the tonsil. Now I was telling you, the fact that internal carotid is 1 centimeter deep to the tonsil has two implications. For quinsy, you know what is the treatment of quinsy? Immediate incision and drainage followed by tonsillectomy. So immediate incision drainage means you put a needle through the tonsil and you drain the pus from the peritonsillar space. So if your needle goes too deep, because internal carotid artery is just deep to the tonsil. So if your needle goes too deep, then it may pierce the internal carotid artery and that might start bleeding. Right? So you have to be careful that your needle or your whatever you are using to drain the pus should not go more than 1 centimeter. So there is a special kind of needle, bayonet we call it, special kind of instrument which is a sharp edge like this. So if this is the end that is going to perforate the tonsil, there is a guard here. There is a guard here, and then there is a handle here. These are the handle that you hold, and this end is going to pierce the tonsil. So from here 1 centimeter deep is this shield or guard. So even if you pierce too much accidentally, this cannot go more than 1 centimeter because of this guard. So we have a special instrument. So we take so much precaution because of this. Because otherwise, what happens is when you try to, even if you are very experienced and you are very careful, if you pierce 1 centimeter, but when the patient has pain, patient might react, so he comes forward, he comes 2 centimeter forward, and you are going 1 centimeter deep, so total difference is 3 centimeter. Will go through and through the carotid, and then the patient will bleed to death. That's why this is important. And therefore the second implication is that before you do any procedure in the tonsil, whether you drain the pus from in quinsy or you do a tonsillectomy, anything, you must feel for the pulsation. You must look for the pulsation. If there is a pulsation in the tonsil, then either you have to abandon the procedure, you cannot do the procedure, or you have to be very, very careful. You investigate the patient properly, do the scan, CT scan, see the relation of the carotid with the tonsil, how far it is, can you do a surgery, is it possible? So you have to be more careful. You cannot take it lightly. So that's why this becomes, so there are two implications. A, incision and drainage in quinsy, you only can go maximum 1 centimeter. And B, during any procedure in the tonsil, you have to be careful. So look for pulsation and investigate if there is a pulsation in the tonsil before you even touch the tonsil. Okay, next one. This one is a simple one. Identify the maneuver in the image. Is it Heimlich maneuver, Cottel's maneuver, Apley's maneuver, none of the above? And we all know this is Cottel's maneuver. Which is done for, yes, correct, AB, Cottel's. This is done for DNS. So suppose the DNS is on this side, like this, and the obstruction is on this side. Patient is complaining of obstruction on this side. So you pull the cheek of the same side. So what happens is, if the obstruction disappears, then it is positive Cottel's test. If no change, that means obstruction is still there, it is negative. This is the interpretation of Cottel's test. If the obstruction on doing this disappears, if the patient says, now I can breathe. See, when you pull in the cheek, this part of the nose gets pulled here, in this side. So space gets created. Remember, you can understand. So the space gets created and the breathing starts. So this is positive Cottel's. Now the implication is that positive Cottel's tells you that DNS or obstruction is at the nasal valve area. There is an area called nasal valve area, so obstruction is there. That's why it disappears. So it tells you the site of the obstruction. The main importance is that it tells you the site of the obstruction, and nasal valve is the narrowest part of nasal cavity. This is another MCQ. This is the narrowest part of the nasal cavity. That area is called nasal valve. Nasal valve has 3 boundaries, and you should know the boundaries also if you are interested. Now Heimlich is done for foreign body in the airway. So if there is a foreign body in the trachea, then you go behind the person, you encircle around, and then you push. That's called Heimlich maneuver. Apley's is for BPPV. Very, very important. You should be able to diagnose Apley's by looking at the image also. Right. Next one. A 6-year-old child with mouth breathing, high arched palate and failure to thrive. Likely diagnosis or cause: tonsillar hypertrophy, lingual tonsil, adenoid hypertrophy, quinsy. So this is mouth breathing, there is high arched palate, and there is failure to thrive. So very simple, very straightforward. What is your answer? AB saying adenoid. What do you say? Rest of you? Anybody wants to answer this question? Adenoid is the correct answer. See, when we draw again this diagram and we divide into 3 parts, normally we breathe through the nose like this. This is normal breathing. And adenoid lies in the nasopharynx here. So when there is adenoid hypertrophy, the child cannot breathe from the nose. So the child becomes mouth breather. Child is to breathe from the mouth. And in adenoid hypertrophy, there are some changes on the face, and the changes are called, due to adenoid, are called adenoid faces. So because of the adenoid, because the patient is breathing through the mouth, some changes will happen. They are called adenoid faces. And one of the main findings of adenoid faces, feature of adenoid faces, is high arched palate. This is the main feature of. There are many things, 4 or 5 findings, but this is one of the main thing. High arched palate, crowding of the upper teeth, then pinched nose, small maxilla, and dull expression. These are the 5 findings due to adenoid, and they are together called adenoid faces. And because the patient is not breathing through the nose, which is a normal area of breathing, then sometimes patient lands up into serious trouble. Weight does not gain, the breathing is not proper, so patient life becomes compromised. So that's failure to thrive. So you have to do adenoid hypertrophy, adenoidectomy surgery to relieve this problem. Next one. Laryngeal crepitus is absent in glottic carcinoma, post-cricoid carcinoma. Laryngitis is a normal finding. So in which of the following laryngeal crepitus is absent? Glottic carcinoma, post-cricoid carcinoma, laryngitis is a normal finding. And the correct answer is post-cricoid carcinoma. Now laryngeal crepitus is also called MUIR, Muir crackles. This is the second name of laryngeal crepitus. What is this? See, we all know that larynx is made up of cartilages, and the lowermost cartilage of the larynx is cricoid cartilage. So again, that similar diagram. So this is your larynx, and the lowermost part of the larynx has a cartilage called cricoid. We all know cricoid is a complete ring cartilage. This is only ring cartilage. Rest of the cartilage is open from behind. So rest of the larynx is open from here. Cricoid is complete. And behind there is vertebra. So there is a vertebra here. There is a vertebra. The other vertebrae also. So what happens is, if you hold your larynx and push behind a little bit, so that it comes in contact with the vertebra. Of course, there are few layers of mucosa, and if you turn it side to side, there is a friction between this cricoid and this vertebra, and this friction between the cricoid and the vertebra produces a sound. A sound is produced. Two things that rubs against each other, there is going to produce the sound. This sound is called laryngeal crepitus or Muir cracker. Cut. You can try it. You put your hand on the larynx, push it back, and turn it from side to side. It tells you. So you can hear that cut awaz, crittly sound. That's called laryngeal crepitus, Muir cracker. Now this tells you that there is nothing between the larynx and the vertebra. Obviously, because both must be very close to almost contact. Only then you have this sound. So it has to be normal, nothing between the larynx and the vertebra. If there is anything between the two, if anything comes in between the two here, so you cannot have this sound, because now they cannot come in contact, so there cannot be a sound. So there will be absence of this cracker. So when this is absent, what it tells you is there is something between the larynx and the vertebra, and that something could be a tumor in this area. There could be an abscess, there could be some growth, there could be some foreign body here. Anything between the two will cause absence of laryngeal crepitus, right? So glottic carcinoma is larynx, inside the larynx, so no problem. Laryngitis is again problem of the larynx, nothing between the larynx and the vertebra, and I told you it's a normal finding, right? So in post-cricoid is behind the cricoid. The name post-cricoid carcinoma is behind the cricoid. Post-cricoid is a part of hypopharynx. So they can also ask you hypopharyngeal carcinoma. Instead of postcricoid, they can say hypopharyngeal carcinoma. It is still okay to say. Or retropharyngeal abscess. In retropharyngeal abscess, the abscess is here. There is a pus here. Here, there is a pus. So retropharyngeal abscess, again, you will have the same thing, right? Now, when you don't have this sign, absence of laryngeal crepitus is a sign. It's called Boca sign. Some books call it Jackson's Trotter's sign. Sorry, it's sometimes called Trotter's sign. Don't confuse with Trotter's triad. Trotter's triad is laryngeal nasopharyngeal carcinoma. We know that, but this Trotter's sign is not commonly used term. Trotter's sign, but Boca sign is important. It's absence of the laryngeal crepitus. So when you have this sign, which is same as this, that means there is something between the larynx and the cricoid. It could be postcricoid carcinoma, it could be hypopharyngeal carcinoma, it could be abscess here, it could be foreign body, anything. Right. Next one. An infant presented with inspiratory stridor. The laryngoscopic finding was done. I missed. The image is not here. I'm sure you know that there was an image showing the epiglottis. Epiglottis, which was almost this shape. So by mistake, the image has not been put. But since you have already attended the lectures and you know that what the image was like. So what is the answer? Is it laryngomalacia, epiglottitis, croup, vocal cord palsy? This was a case of laryngomalacia. Especially infants, any of this disease does not happen in infants, not in infants. That's one of the, and inspiratory stridor can happen in all of them. Inspiratory stridor is not a leading point because it can happen in all of them. But the main thing was the examination, which shows you omega shaped epiglottis. And that's why it's laryngomalacia. It's a congenital defect. In epiglottitis, there is a thumb sign, but this is X-ray. And croup is stipple sign. Again, it is on X-ray, not on laryngoscopy. So very good lead was they gave you a laryngoscopic finding examination, and that tells you it is laryngomalacia. It cannot be thumb sign or stipple sign because they are seen in X-ray. Next question. Now, I've shown this image so many times in every lecture I show you. Identify this image. Is it Holman-Miller sign, Trotter's sign, Aquino sign, Hondusa sign? I think Trotter's was not given the choices, whatever was there. I don't know. And I'm sure everybody can answer this question straight away. What is the answer? Okay, Deepen is Holman-Miller, AB is Holman-Miller, is a correct answer. Is also called antral sign. The other name is antral sign, isn't it? And this is seen in juvenile nasopharyngeal angiofibroma, where the posterior wall of the maxilla is pushed anteriorly, as is shown with the arrow. Hondusa sign is also seen in JNA. This is also seen in juvenile nasopharyngeal angiofibroma. Trotter's sign I just told you. Trotter's sign is the other name for Boca sign. And Aquino sign is seen in glomus tumor. See, nasopharynx, you have nasopharyngeal carcinoma treatment, a question on nasopharyngeal carcinoma, you have a question on angiofibroma, and so many questions from this area. Oropharynx, you had a question, tonsil, pulsation, you had hypopharynx, postcricoid carcinoma, that this sign, absence of laryngeal crepitus. So a lot of questions from this area it asked this time. Now what I'm trying to show is, this is the image that I showed you, isn't it? Now please note very carefully, this is very, very important because they can trick you this. Nobody is going to tell you this. Please identify this. See, in this, which is the most common site of juvenile nasopharyngeal angiofibroma? Most common site is sphenopalatine foramen, which is either nose or nasopharynx. Some book says nose, some says nasopharynx. It is at the boundary. Look at the nose. Look at this nasal cavity. No tumor. Look at this nasal cavity. There is a tumor, isn't it? So this tumor has gone inside from here, like this, from the nose to the behind the maxilla, which is pterygoplateral fossa, and push the tumor, causing this side. Now look at this one. Same. Can you see this? Again, the maxilla is pushed. Compared to this maxilla, this side, which is not pushed. But look at the nose of that side. Look at this nasal cavity, this side. Is there any tumor, any growth in the nose? Nose is absolutely normal. There is nothing. You can only see a turbinate. That means this tumor is not coming from the nose. And therefore, this is not antral sign. This is not Holman-Miller sign. So, if I give you this image, and if I ask you what sign is this, I'm sure 99% will say this is also same thing, Holman-Miller sign. But this is not, because this is not angiofibroma, because this is nose is normal. So, look at the nose. This is coming from the parotid. This area is the parotid. Can you make out? It's coming from the parotid. If you look very carefully, see the tumor can be seen to be traveling in this direction. So it's a parotid tumor that has gone behind the maxilla and pushed the posterior wall of the maxilla. Therefore, it is not antral sign. But look at similar finding in this one. See, the finding is very similar. But look at the nose. Nose is occupied. So the tumor is coming from here. So this is antral sign or Holman-Miller sign. Okay. So you have to be careful when you talk about angiofibroma and Holman-Miller sign. Look at the nasal cavity also. If it's not coming from the nasal cavity, the nose is normal, nasopharynx is normal, there is no growth there, then most likely this is not angiofibroma. Therefore, most likely it is not this sign. Okay, right. Which of the following conditions decreases bone conduction? This is the first thing I tell you in my lectures, almost when I start the lecture with the help of a diagram. Fixation of the foot plate, external ear disease, cochlear pathologies, all of the above. So what is the answer? A, B, C, D, fixation of the foot plate, external ear pathologies, cochlear pathologies, or all of the above. I don't know what are the choices, but two choices I'm sure were there, first and third. So what is the correct answer? Please answer this one. And the correct answer is cochlear pathologies. We all know that there are two types of conduction, AC and BC. Air conduction, bone conduction. So I draw like this: tympanic membrane, ossicles, inner ear, eighth nerve and brain. This is almost the first diagram that I draw, and I tell you that in the cochlea there is organ of Corti. AC travels from here and BC travels straight to the cochlea and then to the. So bone conduction goes directly to the cochlea, and therefore it checks the cochlear pathologies. So when there is a cochlear pathology, BC will reduce. If there is no cochlear pathology, AC will be normal. When there is cochlear pathology, it is SNHL, isn't it? If it is disease, yes, CHL. Right? In CHL, BC is more than AC. Remember, in Tunis. So BC is more, not reduce. In SNHL, AC is more than BC because BC is not increase. So in CHL, BC increases. We know this. Even if you don't know all this, if you know your Rhinis test, in Rhinis, AC is more than BC is more than AC in conductive hearing loss, whereas in cochlear disease, which is sensory neural hearing loss, AC is more than BC. So BC reduces in cochlear disease. So that's how you correlate between the two. And BC is the most sensitive for checking hearing loss. BC is the most sensitive. If BC is there, then you can find out very easily. If AC is only AC is there, then AC loss is there, then it becomes a little more difficult to confirm. But if BC is gone or decreased, then it is even 5 decibel decrease in the BC you can diagnose with a 24. BC decreases with 5 decibel. If BC decreases by 5 decibel, you can diagnose. But for AC to diagnose, minimum decrease has to be 15 decibel. Less than 15 decibel decrease in the AC, you can't make out. So BC is very, very sensitive. Cochlear pathologies. Okay. A patient presented with neck swelling, unilateral hearing loss, temporoparietal neuralgia, pain, most likely diagnosis, we all know. Is it nasopharyngeal carcinoma, hypopharyngeal carcinoma, Oropharyngeal carcinoma or juvenile nasopharyngeal angiofibroma? Again, I'm sure most of you can answer this question. Please answer. I'm waiting for your answers. Yes, nasopharyngeal carcinoma. These three features, especially hearing loss, these two are seen. Plus, if you have plus soft palate palsy, if you have these three, then it is Trotter's triad, isn't it? And Trotter's triad we all know is nasopharyngeal carcinoma, but in this case, instead of soft palate palsy, they gave you neck swelling, which is lymphadenopathy. In nasopharyngeal carcinoma, we already know that lymphadenopathy is the most common presentation. We know this already. So this combination straight away nasopharyngeal carcinoma, which is again, I tell you, a very important topic. We have discussed it so many times. And this is the second question about this. So many questions from this area. Okay. So this will complete all the questions that I got from you guys. You are the guys who gave me questions and I prepared this. Choices were given by you. Many of you could not remember some of the choices, so I framed it accordingly. But anyways, thank you so much for giving me the questions so that I could carry out this session of ENT. And I hope this was useful to you. Please look out for ENT sessions in Unacademy platform. And before I leave you, again, I'll tell you about this iconic subscription, where I tell you that there is a combo pack where you get a subscription of Unacademy plus an app. And there were 15 questions, I'm told, of ENT this time. And this is what they say, 15 questions they ask you. When they start next exam, the name of the exam is next, not next, as in next exam, they will have 60 questions of ENT. So the importance of ENT is going to increase 4 times, 400% will increase. So ENT is going to become hugely important when the next exam starts. So of course, once you clear this MCI, you're going to write next for PG, isn't it? Next exam you're going to write for PG. And then ENT becomes very, 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 very important. So please join the ENT course on Unacademy platform. I teach you all the important topics in details. So look out for the next batch whenever it's starting. Instead, in case you want to write either MCI again or you want to write PG entrance exam, you must join because too many questions from ENT. You can't afford to relax or ignore ENT. Okay. But for iconic subscription, you can look at the website for all the different kind of, you have different categories of plans you have. So according to your requirement, you can take up and you can download the app for free plans by using this code Dr. Sanjay 10. So that was it today. I hope I've been able to do justice to these questions. Please keep working very, very hard. Thank you for attending. God bless you. And best of luck for everything that you do in future. So bye for now.